Thank you, Reg. That was great. As you all know, the hiatal repair in paraesophageal hernias, it's Achilles' heel. And Steve DeMeester has done some incredible work in the repair of paraesophageal hernia. And so we're really thankful to have him here, and hopefully he'll share some wisdom with us. And Steve, welcome. Let me know if there's anything I can do to help accommodate your situation
thanks.
here.
I'm working on tendon repair right now. So I'm going to ask your indulgence. I'm just going to sit down on the stage here and keep my foot up. I got in trouble by being too aggressive too quick and got infected and reoperated, so I got to sort of pay attention to my orthopedic surgeon now. I guess he was right to take it easy. Yeah, I give that same advice to my patients all the time, and then I didn't do so good on my own. Anyway, so do we have the clicker? So I'm going to talk about this paraesophageal hernia issue, and was asked to focus on it being an anatomic problem, which I think it is. So you see in the picture there the pathognomonic X-ray of a patient with paraesophageal hernia, the retrocardiac air fluid level. So pathognomonic X-ray, if you see that X-ray, you can pretty much stop your investigation in terms of what is that structure there that's pathognomonic for paraesophageal hernia. And for the gastroenterologists in the group, that's the laparoscopic view of a gigantic hiatus. So that hiatus has to be closed down to something the size of a quarter. And it's not that magnified. You can see the entire stomach width-wise in that chest. That gives you an idea of how big that hole is that has to be closed down. So that's a challenge for us as surgeons. So I'm going to talk briefly about some paper that is in the peer review process right now on a type of mesh, and I am a consultant for that company, Bard Deval, or now Beckman Dickinson. So I'm a consultant and I have a research grant, and I will discuss a little bit of the findings of this paper, but as I said, it's in the peer review process, so it's not just my opinion at this point. So first of all, I want to make sure we're on the same page for types of hiatal hernias. There's 4 subtypes, but 2 important categories. The sliding is the most common hiatal hernia, and we've talked a lot about hernias today, and I think it's very, very important that in our minds and in our notes and in our discussions with the patients, we point out which hernia is present and which one they have, because it's critical, because the indications for operation, the potential complications, a lot of things are different between the 2 types of hernias. So it's really important that we focus ourselves and make sure we let patients know what type they have. So the sliding is the most common. It's associated in most circumstances with reflux disease. You can have a hernia. About a quarter of the population has one. In fact, a new study from Finland suggests that almost 50% of the population in Nordic countries have a hiatal hernia. Many are asymptomatic. So I'm not quite sure that John's correct that 90% of patients with a hiatal hernia or a large hiatal hernia have reflux. It's a very common problem. But you definitely can get reflux, and I won't show the data, but there's a number of studies that show as the hernia gets bigger, the likelihood and the severity of reflux correlate and tend to get worse. Sliding hernias are more common in men. Now, paraesophageal hernias are different. They're increasing dramatically in incidence. They're primarily present in elderly females, but men can have them as well. GERD symptoms are much less frequently present. They can be present. In fact, it's interesting. Oftentimes, patients will say, I used to have GERD, then it went away. As Reg just showed you, the anatomic distortion in that picture he showed you was a paraesophageal hernia. The anatomic distortion related to a paraesophageal hernia oftentimes stops the reflux. So the reflux symptoms can go away in these patients. Much more common are non-reflux symptoms. Chest pain, discomfort after eating. They can't tolerate solid foods very well. They feel uncomfortable. Sometimes they feel short of breath or dyspneic on exertion after a big meal. More subtle things. And anemia is common. We'll come back to that. And as we said, it's more prevalent in elderly females. So to make sure we're on the same page, let's just go through some basic anatomy. Sliding hiatal hernia, the key distinction is that the gastroesophageal junction is on top of the herniated fundus. There's several types of paraesophageal hernias, but the important concept is that the herniated stomach is above the GE junction. So the rare type 2, the true paraesophageals, are really very uncommon. I've seen one or two in my life, but they're the GE junctions in the abdomen, but the fundus or a slip of fundus has gone up in the chest alongside the esophagus. Much more commonly, the type 3 or the type 4 paraesophageal hernias, distinction being type 4, there's an associated organ in the chest besides the stomach, so it could be the colon, pancreas, other things. But again, the GE junction is below the herniated portion of the fundus. Sometimes in the big upside-down intrathoracic stomachs, it can be hard to see where the GE junction is, but it's always down towards the bottom of that upside-down stomach. Of course, with the type 3 and type 4 paraesophageal hernias, the concern is the potential for volvulus. In fact, if you have upside-down or volvulized stomach, the most common one is the organoaxial volvulus, where the stomach's flipped upside down. Mesoaxial is when the stomach folds in half. Both of those are volvulizations of that large hernia, and that's one of the complications of a paraesophageal hernia. Now, you can tell that on an X-ray quite simply. In the X-ray on the left-hand side there, you see the GE junction above the herniated fundus, sliding hernia. When you see the GE junction below the herniated fundus, of course, that defines paraesophageal hernia. And in the upside-down stomach, you don't really need to see where the GE junction is. If you have an upside-down stomach like that, that is a paraesophageal hernia. Importantly, you can tell that endoscopically too. I read dozens of endoscopic reports a week in the clinic, and I'll tell you, it is rare to see a report that determines whether they see a sliding or paraesophageal hernia. It's very, very rare, and there's no reason for that. If you're doing an endoscopy, you should, as part of your practice, be saying in your report whether it's a sliding or paraesophageal hernia, because it matters. Here's how you tell. If you retroflex, you have to retroflex generally in order to tell. Although, if you drive into a stomach and all you see is stomach everywhere and you can't find your way to the pylorus, that's a volvulized paraesophageal hernia. But in general, the best thing to do is retroflex. And if you retroflex and you see the GE junction at the very top of that crater of herniated stomach, that is a sliding hernia. When you retroflex and it looks like a Hill grade 1 valve and you see this GE junction standing proudly in the middle of that herniated stomach, that's a paraesophageal hernia. The herniated stomach is above, higher, more proximal in the chest than the GE junction. So endoscopically, you can tell the difference, and that should be in every one of our endoscopic reports. So what are the risk factors? John Lipham talked a little bit about some of this. No question, gender. Of course, men for sliding, females for paraesophageal hernias. Hernias increase with age. Obesity is a risk factor. Hiatal anatomy, as we said, the right side of the diaphragm is particularly important. Patients sometimes have more of the diaphragm constructed by the left crus, and they have a higher likelihood of hernias. Kyphosis is very important for paraesophageal hernias. It changes the dynamics at the hiatus and leads to these paraesophageal hernias. John talked about the collagen and curled muscle abnormalities that have been demonstrated. And family history. There's a couple nice studies that demonstrate a genetic family history component to these hiatal hernias. So we had an interest a little while ago, and I apologize to those of you that were recently at our Hawaii course. I went through this data, but I thought it was good to share with everybody. It has not been published yet. We were interested in the development of these hernias, particularly paraesophageal hernias. So we had the opportunity in Portland to review the upper GI studies from the Providence system, and we could review a report and search for the word hernia. So we reviewed the reports and found the word hernia, but it could, of course, when we dug out the report, it could say no hernia, or it could say hernia. So we dug through almost 50,000 X-ray reports and identified about 13,000 where the word hernia was used, and then defined further whether it was no hernia or hernia. And then we went on to look at patients that had at least 2 upper GIs, because if we're going to look at the natural history, 1 won't do it. So we a priori selected a 5-year interval between upper GIs to see what was happening in these patients with a hernia. So at the end, we had 210 patients with a total of 526 upper GI studies that were reviewed. 121 of the patients, the images were inadequate to reliably confirm either the presence or type of a hernia, so we deleted or excluded those. 21 patients clearly had no hernia on baseline upper GI, clearly had one on the subsequent upper GI, and in 68 patients, there was a hernia both at baseline and the subsequent upper GI. So in the end, we had 89 patients, 27 males, 62 females, and here is how they broke down. So 21 patients with no hiatal hernia on the initial upper GI at a median time interval of 99 months. The second upper GI in these patients showed a sliding hiatal hernia in 16 patients and a paraesophageal in 5. So in 5 patients, there was no interval sliding hiatal hernia that we could detect. Now, it's possible that they had one for a short period of time that quickly went on to a paraesophageal, and we're going to try to look at smaller intervals and see if we can look at that in more detail. But at least at this point, it looks like patients can go from no hernia straight to paraesophageal hernia. In those that had a sliding hiatal hernia, 55 of them, it was stable in only 11 patients. The size increased in 30 and changed to a paraesophageal hernia in 14. So a large percentage, what was it, 80% of those patients that started with a sliding hiatal hernia, over an interval of 84 months, that hernia in many of these patients either got bigger or changed to paraesophageal. And the paraesophageal hernia patients at the first upper GI, there were 13 of them. Again, at the 97-month follow-up upper GI, it was stable in 5, increased in size in 8. So again, more patients than not over the interval had a change in their paraesophageal hernia. This shows you that these hernias, whether sliding or paraesophageal, are not static. They change with time and tend to get bigger or convert to paraesophageal over time. We had 23 patients that had more than 2 upper GIs, so they had a third or a fourth or a fifth upper GI down the road. So we looked at those in a median time interval from the second to the most recent, 42 months, stable again in only 3 patients, increased size in 9, and 1 changed to paraesophageal hernia. So again, with further follow-up, another 77% of these sliding hiatal hernias progressed. In the 10 patients that had further upper GI studies for a paraesophageal hernia, same thing, 50% changed. Now, 2 already had a complete intrathoracic stomach, and you can't really get any bigger or worse. So it's actually more than 50% that potentially would have progressed in that group as well. So don't think of a hernia. When you see a patient with a hiatal hernia and they're having some symptoms, and they come and they've had an upper GI or a scope 3-4 years ago, don't think that hernia is the same and you just got to tweak your medicines. Time to relook at that hernia because it's probably changed, and some of their recurrent symptoms may well be because that hernia has gotten worse at this point. So what are the implications of a paraesophageal hernia? Number 1, symptoms, of course. You can have reflux symptoms, chest pain, heaviness, like we talked about. Anemia, another important, not a symptom, but a sign. We'll circle back to that in a minute. Acute incarceration or obstruction related to the volvulization of these hernias. The estimated risk is about 1% per year in a patient. It's higher in patients with worsening symptoms. If your patient is having repeated episodes of chest pain, that 1% is probably low. They're on their way to trouble. If a patient's admitted with acute obstruction, the best treatment in most of our opinion, is to try to decompress them promptly with an NG tube. If you can get the NG tube in, great. If you can't, you might need an upper endoscopy to decompress it. Taking these patients emergently to surgery is difficult. The fundus is very, very swollen, and it's not an ideal time to do a repair on these patients. So if you can decompress them for 48, 72 hours with an NG tube, it makes the subsequent surgery much more effective with healthier tissues to work with. So most of us think that's the ideal treatment, and then repair it usually before they leave the hospital. Now, if they present with perforation or acute gastric necrosis ischemia, then obviously they need an urgent surgery. That requires generally some type of resection, proximal, or sometimes subtotal gastrectomy to address this. The mortality with these emergent operations remains very high, upwards of 10% in most series. And this Professor Silvo presented or published this a number of years ago. It's pretty interesting. The fatal complications of paraesophageal hernias. Of 29 patients that died from acute paraesophageal complications, most of them, 55%, were known to have a paraesophageal hernia before the hospitalization that led to their death. And those of you that are surgeons and take care of these patients, you know that. When you see a patient in the emergency room with an incarcerated or problematic paraesophageal, most of them have been told they have a hiatal hernia. The unfortunate thing is most of them were never told they had a paraesophageal type hernia. Most of them said, yeah, my doctor's told me for years I have this hiatal hernia. Never been told they have a paraesophageal hernia which has this exact risk. So it's a shame if somebody dies from something that they never knew they had when they should have known that they had it. We're going to talk about why that's important in a minute. So let's circle back to anemia. This is a paper from 1967 by Lee Collis, the guy that described the Collis gastroplasty, which we'll talk about a little bit later. But he published this way back in 1967, demonstrating for the first time the very clear association between a paraesophageal hernia and anemia, and the resolution of anemia with correction, with surgical correction of the paraesophageal hernia. He found it present in 30% of his patients that had a paraesophageal hernia. Interestingly, way back then in 1967, he attributed it to three forces: the negative intrathoracic pressure, the curl muscle movement, the sliding movement of the stomach across the hiatus, and he called these riding ulcers. And he showed that most of the time with repair of the hernia, the hemoglobin rose. So it's interesting that 20 years later, Alan Cameron gets the credit for calling these Cameron lesions. Nonetheless, these studies have been repeated. Don Lowe, who I know is here, published this nice paper showing the resolution again in the majority of patients with paraesophageal hernias, and nicely showing that the resolution is independent of whether you see Cameron lesions on your endoscopic evaluation or not. So whether or not you see Cameron lesions, most of the time the anemia is from the paraesophageal hernia. Fix the paraesophageal hernia, and it usually gets better. So what are the indications for repair? Prior to 2002, repair was indicated upon diagnosis of a paraesophageal hernia in anybody that was fit for surgery. That was based on old data showing a very high risk of progression. That all changed when Dave Ratner and colleagues in 2002 used one of these Markov analyses of 50,000 hypothetical patients that said that watchful waiting was the best approach for an asymptomatic patient 65 years or older with a type 2 or 3 hernia. Now, oftentimes that gets misapplied to anybody that's asymptomatic with a paraesophageal hernia. That's not what this paper shows. Today, if you are under 65 with any type of paraesophageal hernia, you should get repaired. That Markov analysis does not apply to patients under 65. If you're of any age with a type 4 hernia, with colon or something else in the chest, this Markov model does not apply. Or if you're 65 or older with any symptoms, including anemia, the Markov model does not apply. So the asymptomatic thing, it's not a broad stroke across everybody with paraesophageal hernias. So it's important to recognize that. And what's also interesting in that paper from quite a while ago now is that they said if they changed their Markov model and the elective surgery mortality rate dropped to or below 0.5%, it would favor repair in everybody, symptomatic or not. Our most recent data from elective paraesophageal hernia repairs suggests we're there now. Elective laparoscopic paraesophageal hernia mortality rates are now less than 0.5%. If we redid that analysis, it may change everything. Issues for surgeons. Real quick, we'll cover a couple things. These are complex repairs. These are the Mount Everest of hiatal hernia surgery. It really should be done by experienced high-volume surgeons, not the occasional foregut surgeons. There's a high rate of recurrence, and there's a number of factors that contribute to that recurrence. But we're learning, like other hernias that we fix, tension is a problem, and it's important for us as surgeons to address that. There's been 2 randomized trials looking at the use of mesh. I'm not going to spend a lot of time here. But if you look at the Oschlager trial, at 6 months, the mesh seemed to be beneficial. By 5 years, at the right side of the graph, the mesh was not beneficial, and you can see almost a 50% recurrence rate. In the Watson study from Australia, you can see no difference at 6 months between mesh and no mesh. So we got some issues, and it's a challenge for us as surgeons. We have weak tissues, elderly patients, these huge defects that we have to repair, and tension. So I won't go into it too much, but it's important as surgeons that we understand tension and techniques to reduce tension. This is a nice study by Bradley Davila, one of our partners, and Ralph A. that showed that these tension-reducing techniques do work. They do reduce the tension of bringing the crura together. That's what a right-sided relaxing incision looks like. You make a hole in the diaphragm, close the crura, patch the hole in the diaphragm as a separate step. The Collis gastroplasty, we alluded to Lee Collis earlier, a technique to lengthen the esophagus, take the tension off of your repair if you have a short esophagus. And this is the data from the paper we just presented or published, or it's in review actually. 50 patients, all elective laparoscopic paraesophageal hernia repairs at our center. Fundoplication in all of them. 42% had a Collis gastroplasty, 4% had a relaxing incision. We used a bioresorbable mesh for crural reinforcement in these patients, and objective follow-up at 1 year in all these patients showed an 8% recurrence rate. So suggesting that taking tension off can help, because there were no recurrences in patients that had a Collis gastroplasty or relaxing incision. So we're beginning to learn that we can do things to improve the outcomes in these patients, although again, most of these recurrences that we see are asymptomatic and don't need repairs and are not associated with the same risk of volvulization and carceration that the primary paraesophageal hernia was associated with. So in conclusion, paraesophageal hernias are indeed an anatomic problem. They're likely related to age, kyphosis, and collagen defects, and they tend to get bigger over time. So don't think of them as a static situation. Anemia is common. It resolves with paraesophageal hernia repair. So if you have a patient with anemia and you find a paraesophageal hernia, the most expedient thing to do is fix the paraesophageal hernia. If the anemia does not go away, then pursue more detailed investigations. Patients with any symptoms, patients with type 4 hernias, and patients under the age of 65 should have their paraesophageal hernia repaired at the time of diagnosis. Surgical repair is challenging, best done by experienced surgeons, but we're making inroads into getting better outcomes. Thank you very much.
Time to stay there.
Oh, okay.